The Austin Love Doctor, Episode 007. Get the most from your physician with Brooklyn cardiologist Dr. Warren Wexelman.
This is Dr. Charles Reynolds, inventor of the O-Shot, and thank you for joining Dr. Emily Porter, the Austin Love Doctor, as she openly discusses your most intimate questions regarding relationships, sex, and personal wellness through the eyes of a medical doctor who treats men and women for a variety of sexual issues using the latest medical advancements available. Get comfortable, relax, and welcome your host, Dr. Emily Porter.
Hi, this is Dr. Emily Porter, the Austin Love Doctor, and today I have a special guest with me, Dr. Warren Wexelman, who is a cardiologist in Brooklyn. He's known as the Rock Doc. He's been a lifelong Brooklynite and has been a practicing cardiologist in Brooklyn for over 30 years, which is where I met him about, 12 years ago now. He was at Maimonides Medical Center, and he served as the Associate Chief Medical Officer, Director of Clinical Therapeutics, and Chair of the Pharmacy and Therapeutics Committee for over 23 years. He also founded the Cardiac Rehabilitation and Exercise Program, which he ran for 16 years. And it is one of the nation's largest academic cardiac rehabilitation programs. He's currently on the faculty of the NYU Langone School of Medicine. He's the president of the American Heart Association of Brooklyn and has been the medical director for the Avon Walk for Breast Cancer in New York City since 2002. In addition to being a physician, Dr. Wexelman also has extensive media experience. He's been on CNN, Good Day New York, NBC, and he was a regular guest on the Fox series Fox on Health. He had an acclaimed radio show called Second Opinion, which aired in New York City from 1999 to 2001. And last year, in February of 2018, he teamed up with Bob Harper, who was the celebrity fitness guru from TV's Biggest Loser, who had suffered a sudden cardiac death and a major heart attack while exercising in the gym. And they went on a national media tour together, which was covered by TV, radio, and print, as well as Facebook Live. He's also been himself on a couple reality TV shows, and he is a lifelong musician, loves playing piano, keyboard, guitar, and sax. So I hope you join me in welcoming Dr. Wexelman to our show today, and we're going to answer some of your questions that you have about how the heart and the cardiovascular system play into sexual function and just kind of go from there. So Dr. Wexelman, thanks for joining us.
I got to tell you, Emily, with all the stuff that I've done, with all the shows and things that I've done, even my own show, it's so exciting to be on your podcast and to hopefully become a member regular of your family. It's so wonderful to see, how your career has taken off and where you are. So I'm very excited about this today.
Well, I appreciate it. We're excited to have you too. You and I, when I was in residency, we didn't talk much about sex. It wasn't really something that was, we didn't really get any training on it. I did psychiatry rotations in both medical school and residency. I certainly did OB, obstetrics and gynecology, both in medical school and residency, and urology. And I don't really know that we talked a lot about sex and defining sexual dysfunction. And certainly in pharmacology, we never talked about these medications and how they might, these commonly prescribed medications and how they might affect people's sexual function. I didn't even know that birth control pills affected libido and free testosterone until I started doing what I'm doing. And that was the first thing I did. My husband got snipped and I went off the pill. And I'd been on it for 20 years.
It's interesting because, when you think back at all the time that you and I spent together during your residency training and the close friendship that we developed, talking about sex was not something that we talked about very much unless it related to patient's illness, but that was a while ago, all right? That was when the world was in a much different place. Healthcare and relationships between men and women and doctors and patients were in a different place. Can you imagine, and I know you can, of course, because you're still a practitioner, what it's like now? There's no discussion about sex now. I think that one of the things that has really been a detriment to the world, we've lived through sort of this new coming of age of of women's rights and Me Too, and, the ability of, there are certain things, just not going to be applicable in our society anymore. And rightly so. The whole issue of taking advantage of women, men, or, anybody, has become such a hot, topic. And people, I think, are afraid. I think that if you talk to men and women, they're kind of nervous, especially I think men and younger men are very nervous about talking to women or having a conversation, or, even as much as saying hello now has become such a challenge. People don't know what to do anymore. And it's a big difference between, creating a sexually charged situation or talking to somebody and saying hello. Doctors never felt comfortable talking to patients about sex. When I grew up in the early years of my medical training, we weren't taught to talk to anybody about sex at all. Cardiologists may be a bit more than the average physician, because we had to answer questions about what to do after a heart attack and what to do if you have heart disease. So I think that one of the things about the Me Too world that we live in today is, I think it's scaring doctors from talking to patients for fear that it might not be taken in the manner in which they want it to be taken. And second, I think it's scaring patients off from wanting to talk to doctors for the same reason. So I think that a lot is going to be lost here with this.
Yeah. Well, I read something today, actually, that said in one of my medical websites that said that physicians are going away from just shaking a patient's hand, introducing yourself, and don't even want to shake somebody's hand and introduce yourself.
Emily, you know me very well. You know that I'm a very personal. You and I always got along so great. We would see each other in the hallway, hug us and kiss each other. Hello. I'm afraid these days to forget about shaking hands. You don't want to look at somebody the wrong way anymore. You look at all those people that have, lost their jobs, and most of them are very appropriately so, for stuff that has gone on for so many years that obviously needed to stop then and certainly by now. But I think that people are very afraid to give the impression that they have an interest or, to not be taken incorrectly. So I think it has done quite a bit of damage. But when you look at what you and I do, which is talk to people all day long, because without talking to people, without looking at people, it's hard to get a sense of what their disease process is and what's really bothering them. You and I learned so much. And, we taught you in your training in the emergency department to look at people and observe them. And you learn so much about, what their diseases are and what, how we're going to treat them, and understanding who will take what. And now I'm afraid that that's being lost. So yeah, shaking hands is gone. I don't take anybody and put them in a gown anymore. I'll be bluntly honest with you. You come in here, you get examined, and that's in your full clothes. And, that's sometimes dangerous enough. So I think we're at a place in healthcare where this is really going to become a huge problem to diagnose, treat people, and also to develop a relationship. We both know as physicians that the way to take care of people, to get them better emotionally and physically, is by understanding them, knowing about them, and being able to be one and a partner with them. And when you're afraid to look or shake a hand or to talk frankly with somebody, you can't do that.
Well, I think it's hard too, because you have to have a chaperone. It used to be that you just have to have a chaperone. You went to your gynecologist, and my gynecologist is even a very good friend of mine. And he, even when my husband's there, he doesn't break that rule. He always has somebody come in when he does the exam. But what I'm afraid is that they're going to go to where they have to have somebody in the room the entire time. And I know in my practice, I don't take care of people without, staff there. It's not like I'm treating men at 10 o'clock at night on a Friday or anything, but having just another person in the room can really create a boundary that doesn't always work.
Very
Most of the people are already nervous. They're already embarrassed. And you can tell just by looking at their blood pressure and their heart rate that there's already that barrier there. And if I had a third person in there all the time, it would just make it even more difficult.
Yeah, I think that we're going to have to, as a profession, I think we're going to have to deal with this. And we're going to have to be able to say, when I see a patient for the first time, I try to explain to them that the way to get well and stay well is through a partnership between me and them. and that I will be available to them 24 hours a day, 7 days a week. But they also have to be the partner, and when they're not feeling well, they have to be able to be comfortable enough to call me and not be afraid that I'm going to throw them in a hospital or do some things to them they're not going to like. And that's really the only way. And we as a profession will start with this kind of a dialogue that you and I are having by saying that this is an issue that is now starting and is now becoming a problem. And, we're going to have to overcome it by being genuine. It's a tough world out there for a lot of reasons. Remember, you don't have to pick up any newspaper or any internet today to know how just angry and aggravated everybody is. It doesn't make a difference, side, left, right, middle, up, down. It makes no difference. Everybody is angry. Everybody's looking to beat up on the next person.
I think everyone needs to have more sex and they wouldn't be as angry at the world.
There's no question about it. And maybe that's the whole problem. Well, I know when we're listening to the Austin Love Doctor, that's what it's all about. So let's get right into that sex now.
There's a lack of endorphins in the world. Well, I'm fortunate in that I am my own boss and I don't have to deal with insurance companies. And so I can take the time that it takes to have those conversations. And we do have those conversations. And I, like you, am available to my clients all the time. I get emails at 2:00 in the morning, 3:00 in the morning, and I usually answer till about 1, and then I wake up again at 6:30 and answer. But people don't usually have to wait to get back in touch with me to hear back, and that dialogue is really, really important. And there's not a lot of people out there. Unfortunately, when you get a computer in the way and you've got a chart and you've got to have your back to somebody, which with the electronic medical record, that was one of the consequences. That just added another barrier to the art of medicine. It's become really a bad place, I think.
When you look at it, look at the patient-doctor interaction. And I'm sure all of your listeners will be able to relate to this. So you go into the office with the doctor, you sit in the exam room, and yes, in fact, I just gave a talk in front of a major software company in the United States about changing the whole concept of electronic healthcare. We sit with our backs to the patients. That's the day-to-day. Look at our surgical colleagues. They're not even sometimes in the same room as the patient they're operating on. With robotic surgery, you can be on the other part of the planet. Instead of moving closer to patients, I think we're moving further and further away, and we're being so much more distant. And with the way in which, the world is making us function with this electronic health record nonsense, we're not getting closer. We're not paying more one-on-one time with patients. And it's suffering. Everything we're doing now, everything we're being forced to do is pushing us further away. And I don't think the medical professionals, they're really a bunch of wusses. All of us doctors, we don't stand up. We don't say no. We don't say no, we're not going to do it anymore. You're taking us further away.
We don't say no to corporate medicine. We say no to our patients.
Exactly.
And I think it's really sad that people get their sex education from a porn shop because that's where it's okay for them to have.
So my favorite thing,
not from school and not from a doctor.
Yeah, I'm sorry you're coming through garble. My favorite saying when I give lectures is, you want porn, you go to the internet. Everything is there. You want medical information, you come to me. That's what my job is. And unfortunately, for most of everybody's sexual education, it is right off the internet. And we know how really realistic the world of porn is to reality relationships and sex. It's nowhere even near.
Well, there's actually some science behind erectile dysfunction as a result of overindulging in porn, which I'll get into on another episode. But it actually can affect penile function and cause erectile dysfunction if people get too attached to porn. So
I have seen this in my male patients, that when their entire scale is porn, they can't have a normal relationship because, and this is actually very interesting because it leads us into the talk about sex and with heart disease. I was taught during my internship in medical school that when we speak to patients after a heart attack about sex, we used to tell them?
What?
Sex is probably okay 6 weeks after a heart attack, as long as it's with your usual partner, implying that if it's not your usual partner, the excitement was so much that it would kill you. All right. And what did it mean the reality wise? We would look at the guys and say, basically, either have sex with your wife, and don't forget, make sure she's on the top because you don't want to overdo it, God forbid. Right. And don't have sex with anybody other than your wife because that excitement would be so much you could have another heart attack. And we actually used to tell people this crap. We actually looked at it as it was science. And you know where it comes from? Way back in the 50s, the president of the United States was a wonderful guy named Dwight D. Eisenhower, who was the general who led us out of World War II, who, won World War II. He became president, and he suffered from he had a heart attack during his presidency. And he was beloved by all Americans. I mean, they loved this guy. And his physician was a guy named Paul Dudley White, who wrote all the textbooks of internal medicine and cardiology. The guy was brilliant. And what they did is they stationed a colonel now, at his bedside for 6 months. And his sole function was to lift him up off the bed when he needed to go to the bathroom, use the bathroom, sit him down in the toilet, then pick him up and carry him back to his bedside. They didn't want him, they wanted his heart to rest. The theory behind that was rest the heart and it would heal. Of course, what we didn't know is that his vice president was Richard M. Nixon, and I don't think anybody wanted to see Richard Nixon at that point become president. They were really taking care of Eisenhower. But at the end of the day, the cardiologist's idea of exercise with heart disease or after a heart attack was rest, 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 rest. So that's what we did. So we wouldn't let anybody. In fact, when I was an intern back in 1979, I don't want to say it too loud because I don't want anybody to think I'm not old, even though I am. Back in 1979, we wouldn't even ambulate, get a patient out of bed with a heart attack before the day of discharge. And that was anywhere from 2 weeks to 3 weeks after their heart attack. That's the dark ages. And from that is why I decided to start cardiac rehabilitation programs, because we got you out of bed the next day and we got you ambulate, because we found, the studies have shown that the more appropriate exercise that you get monitored and carefully supervised after a heart attack, the better you're going to do. And it cuts down on second events and it cuts down on mortality. So over the last 30 years, when I started cardiac rehab and we talked about exercise and sex after heart attacks, that was looked at as voodoo witch doctor. There was no science. Now we can say when you start exercising early after a heart attack and with heart disease, you live longer and better, providing it's supervised and prescribed. And what's interesting is that doctors would say to patients, okay, go get some exercise. Patient comes to you and says to you, Doc, I'd like to start exercising. What should I do? You say, okay, go exercise. Walk, this, and that. Exercise is like medication. So is sex. All right? When used correctly, it's wonderful. You have to prescribe it. So what we would do is when a patient has a heart attack, we would give them a symptom-limited exercise test that would tell us what their level of metabolic equivalent, how much can you walk safely? And there's no problem. So then we graduated from you can only have sex with your regular partner. We graduated to is if you can climb a flight of stairs, you can go to bed with somebody. All right? Now, I don't know about the stairs in Austin, but the stairs in Brooklyn ain't all that much. But at least it was a beginning, all right? So we then said, listen, we're going to have you climb some stairs. If you can climb some stairs, you can go out and, have the best sex of your life. And I don't know that was getting closer to it. I think the real discussion that we have with patients right now is that sex is perfectly fine. You go into a hospital now with a heart attack, you get a stent put in, you're out of the hospital the next day. That's after an anterior wall MI that people used to spend 3 weeks in a hospital for, and then again later on 10 days. Now you're out within 24 hours, and there's almost no downtime. And we want you to get back and continue normal function. And the normal function for any cardiologist, for emotional and psychological as well as physical well-being, is to not only include the daily activities of working and running a household, but also to have good sexual relationship, because we know how important that is. So when we see a patient now and they ask me, well, doctor, first of all, I try not to let them ask me. I like to bring it up. I like to say, listen, let's talk about what you can and can't do. We start talking about exercise. We talk about when they should return to work. And we talk about sex right away. And I say, it is very healthy for you to have sex. If I'm telling you that you can go walking, and you can start, a supervised exercise program, you can certainly start sexual activity. Keeping in mind, we're not talking about the internet porn version of people hanging from chandeliers. Most people just want to have an intimate relationship with one they care about. So, it is perfectly fine. You want it because we have to always consider the mind and body as one.
Yeah, I think there's some healing that happens there. I mean, I think that a lot of, at least for men anyway, a lot of their self-worth is tied to their sexuality and their ability to perform. Yeah, and so that's one thing that I think if you can have that back and not be afraid. And honestly, there's, again, we talked earlier about there being not only some cardiovascular benefit, but also some endorphins that are released and some oxytocin and some calming things and definitely some, literally like sexual healing, right, that can happen with that. So I think that's awesome that for men and women to know that if they have a heart attack, even a bad one, that they can go ahead and resume their normal sexual activity, right away within a couple of days. And in fact, it might actually be better for them to do that than to not do that.
If you think about the medications that we use in patients who have heart disease, we use beta blockers. Why? Because beta blockers sort of calm the entire body down, working on the nervous system, working on the rapid heart beating and the forceful heart beating. What we try to do is make the body and the heart rest more. And so what we do is we give them beta blockers, which sort of numb the body's response to stimulants, which is why sexually there's problems with them. We can talk about that in a minute.
Yeah, but beta blockers are, will you define a beta blocker for them so that not everybody might not know what that means?
But what I wanted to say before we get to that is very simply, there's nothing better to relax and calm you down than a good orgasm. There is nothing. When you feel that overwhelming sense of, oh my God, that is so good. You're relaxed. You're total. We try to achieve that. There's nothing wrong with it. But when you're not having that, we give you beta blockers. And what beta blockers are, a medication that we found back in the late 60s and early 70s that first came out to treat high blood pressure. That was the original indication for, propranolol, Inderal, and then metoprolol. And we found that what this does is it works on protecting the body from the body's own stimulants. You and I call catecholamines, what patients may think of as adrenaline and noradrenaline, all the things that make us ready to respond. So if you're standing in the subway, I don't know, do you have subways in Austin? I've not been to Austin, but
no, unfortunately, we have a transportation crisis here.
Okay. So when you're in the subway in the middle of the night in New York and you're the only one standing on the platform and somebody puts a gun in your face and says, I want your money, what makes you decide how rapid to move and how quick to respond is the stimulants, the catecholamines, the adrenaline your body secretes. When your heart is damaged, when your heart is hurting, when the arteries in your heart are blocked, and there's not enough blood that gets to your heart when your heart has to exercise, your heart starts to hurt. So what we try to do is we try to give you these drugs called beta blockers, which block the beta adrenergic receptors that respond to these stimulants. So basically, you're not responsive. And that's good for your heart, and it allows your blood pressure, brings your blood pressure down, it allows you to your heart to rest when it needs to. But look what it does on the other side. It does block a lot of the stimulants that normally you'd be reacting to when you get aroused and when you're starting to feel in the mood for some sexual enjoyment. And that's why when we put patients on this, and as you and I sort of spoke offline about this, it's very interesting because when we look at the sexual side effects of medication, we're always thinking about men and their penises. We're always thinking about, if you tell a guy, listen, there's a chance that you might develop erectile dysfunction from this medicine before they leave your office, Dr. Austin Love, all right, they're going to have erectile dysfunction. Men are so susceptible to just the concept of it. Don't touch my penis. Anything can bring it down. The reality
it's a delicate flower.
Yes. These big, rough, and tough guys, here from Brooklyn, we all got these tough guys. The minute you tell them it could cause them to go down, I don't want that. But what's more important is it's not men. Women suffer from this much more. They just don't talk about it. And, I use a lot of beta blockers in my world. As you know, you came from a hospital that was a beta blocker hospital. You were taught to give everybody beta blockers for 2 things. My God. I use a lot in my practice, and I use a lot in women, because women come in, especially young women like you, come in with palpitations, with skipped heartbeats, extra heartbeats, rapid heart beating, or just anxiety, and they feel palpitations. And although it's not life and death, and we don't have to rush to treat it, if somebody's really bothered by it, where it ruins their ability to function normally, we give them a low dose of beta blockers. And what I have said to every single woman that I have ever given this medication to from day one, I sit her down and I tell her, look, here are some of the things you might feel. You might feel tired, although the dose I'm giving you is low. I said, and you might feel some changes in your desires, especially towards sex. I said, so please, if you find that you're losing your libido, call me and tell me. We can do something about it. Don't wait till a year from now and come in and tell me your husband wants to divorce you, because that's what happens. And invariably, not one patient has ever taken me up on the offer.
Really?
But you would be amazed. Unbelievably so. And then a year later, almost to the day, women will come in and say, Doc, if you don't take me off this beta blocker, I'm going to end up with a divorce. I have no desire whatsoever. Women are very susceptible. Just because they don't have a penis that doesn't get erected. Is that it? Hard. We can talk very openly there, right? So they lack clitoral stimulation from it. They just don't have the desire. And that's what beta blockers do. So there's a lot of ways around it. We have different beta blockers now that we can use. We have very selective beta blockers that don't look at the sex side of the coin, but look more at the blood pressure and the heart rate side. So we can actually give you the right medication to suit your needs. And sometimes with women, if we can, we start that off from the very beginning so they don't even go down the road. Women also get a tremendous amount of nightmares that men don't get on beta blockers. It's very different physiology. One of the biggest problems we see is nightmares. Doc, I'm having these crazy dreams at night, and they're not the dreams we want to have. These are just very frightening dreams. We take them off the drug and it's fine. And we have so many drugs that we can use in the field of medicine and cardiology that we're not tied down. So to your listeners, it doesn't guarantee that if you're placed on any medications, and we see this with diuretics, we don't even understand the mechanism for that. We see it with a lot of the centrally acting, the drugs that act on the brain, that also have a tendency to not allow the excitement and the arousal to occur. Talk to your doctor. Have a conversation. Don't be afraid. It's not, if you can't work the doctor-patient relationship as a partner, you got the wrong doctor.
Absolutely.
And so, and you got to always tell the patients, physicians have to tell their patients, getting and keeping you well is a partnership, 50-50. It doesn't work otherwise, And so when you have that kind of relationship, when a patient can call you up and say, listen, Doc, I just don't feel a desire anymore, and I want to, we get them right off the drug. They're better in within a week.
But Dr. Wexelman, I wonder how many men and women are out there whose doctor didn't even have that conversation when they started them on the medication, especially if it's after a heart attack, and they don't warn them about that. Just like I wasn't warned about libido with when I took some antidepressants, probably in college or med school or something. Nobody warned me about that. Nobody warned me that birth control pills would affect my libido. Nobody told me any of that. And I wonder how many cardiologists and primary care doctors, whoever are prescribing blood pressure medications and also antidepressants, aren't telling people, so they don't even know. And say they had depression, they just think that their lack of libido is due to the depression, or they had a heart attack and now they're on metoprolol and now they don't have any libido, and they think that that's just a result of the heart attack. And that's really, really sad and scary, because I bet so few people are having that conversation on the outset. And I think your patients are so lucky to have that with you, that you tell them that. Don't even let them ask. You just tell them that.
Emily, I will tell you, one of the things that I do is I lecture all over the country. I work for a lot of different pharmaceutical companies as a spokesman for cardiac drugs. and I fly around the country talking to doctors, and I will tell you this. So most doctors are not yet in this day and age having the conversation about cholesterol lowering the way they need to. Trust me, they're not having it about sex, and they're not having it about the intimacy and the medication result. They're not. They're just not. And that's why I think patients have to be their own best advocates. And they have to go in there and they have to be able to talk to their doctor, because you're right. And especially, again, going back to our original conversation about Me Too, doctors are afraid. A young, good-looking, male doctor with a young, good-looking female doctor, a female patient, may indeed be very intimidated to have a discussion. Like, start it off. I've had patients, part of EPIC, the electronic medical record that we're using at NYU, as a whole module where we have to ask very intimate questions about sexuality. With your partners, do you prefer men versus women? Do you like both? What do you do? Do you masturbate? And I got to tell you, we take a lot of heat from it. We take a lot of heat. People do not want to have the discussion. So I would guarantee you that the majority of doctors in the United States are not having the conversation. And I would venture to say, although I don't have data to support it, it's probably a lot of the older doctors, because they're probably more inhibited than the younger doctors who are more open to this. But at the end of the day, I agree with you. I don't think doctors are bringing it up. I don't think they're being proactive about it. We're just trying to get them to think about cholesterol and prevention. You'd think that this would be a natural thing, but I think for the folks that are listening to our podcast today, I think they need to be proactive and bring it up. And if their doctor can't talk to them comfortably about it, either refer them to somebody who can, or just it's time to find a new doctor. And I'm very radical about it.
Yeah. What percentage of people do you think are affected, men and women, for libido or for arousal as a result of being on beta blockers like metoprolol, atenolol, indorol, all those?
I would have to tell you that depending on the generation of the beta blockers, so you sort of went back to indorol. Everybody had sexual dysfunction on indorol. Everybody. Metoprolol, a little more selective, beta 2s. When we talk about being selective for your folks, it means just working on the parts of the body we sort of want to cover and not other parts of the body. I would say it's very common. I would have to say probably close to 60% or more of people that we put on beta blockers have some form of sexual dysfunction, one way or another. I mean, it doesn't have to be only the inability to have an erection and maintain it, but it has to be the interest in wanting to have it. You talked about antidepressants. The disease is the problem, all right? The psychiatric phenomena of anxiety and depression is enough for you to lose your libido completely. We've all been there. All of us have been there. Add on the various generations of anti-anxiolytics, the anxiolytic medication, the SSRIs, and the antidepressants that we use, they numb you completely. Remember what they do, Zoloft, Paxil, Prozac, their job is to level you. No more highs and lows.
Yeah, everyone says they feel like a zombie.
Exactly. They feel like, doctor, I feel numb. Or doctor, I feel like I'm in a trance. But what they're not feeling is the highs and the lows. Mm-hmm. That's what the drug is there to do. It balances the dopaminergic, the dopamine in the brain. So, they're terrible at this. And so once you start to treat their depression, and they could be feeling so much better. And that's why I'm so much against. I treat a lot of anxiety, depression in my practice. Tremendous. Because people come in here because they're scared. Most of them don't have heart disease. They're just frightened to death of it. So we end up putting a lot of men and women on anxiolytics, anti-anxiety medication as well as antidepressants. And I will tell you that, for the most part, you really have to see how they gain weight. Men a little bit, but women can put 20 or 30 pounds on after they start Zoloft or Prozac or Paxil without even batting an eyelash. And then that depresses them 10 times worse. Because now they feel not only do they not have the urge and the desire, but now they feel that they're not good looking and that they don't deserve to have that. So and that's why the doctors, and what my point was going to be, that the psychiatrists who are only writing prescriptions that are sort of doing psychopharmacology, without doing therapy and actually talking to people and trying to get to the root of the source, medications are only a part of it. And we don't sometimes do a great service. It's important to give it, but it has to be followed up with real therapy so that eventually you get off of these medications.
Yeah.
You know, unfortunately, in heart disease, we don't have a tendency to take people off. We just add medications. And the cumulative effect of a lot of medications, you know, are ones that don't affect the sexual prowess of the human being the way we'd like them to. You know, but
well,
then
it would be
again,
uncommon for somebody to have a heart attack and then get started on obviously a beta blocker and then have some depression as a result. I'm sure Bob Harper, and that was the shock to him, a young, healthy guy, and now you have a heart attack and you didn't see it coming and you did everything right and you weren't a smoker and you were in good physical shape. I'm guessing that a lot of depression can come as a result of that. And so I don't think it would be uncommon for somebody to just throw somebody on an antidepressant, and they do it meaning well. I don't think any doctors prescribe people medications to not mean well, but they don't, if they don't warn somebody about the impact that could have, then that can be problematic, especially when you're combining medications. I never stop anybody's medications. I that's not my place. My place is to tell them, hey, you're on a few medications that might be contributing to your erectile dysfunction or your lack of libido, or hey, let's check your testosterone as well. Or hey, why don't you talk to your OB about, a different form of birth control, or your husband about a vasectomy, or, your cardiologist about maybe switching your blood pressure medications. But I never change anyone's medication. But it's amazing to me how many of them have not been told that their medications could be the cause of any of their feelings and thoughts that they're having that end them up in my office in the first place.
Well, when you work with them, I think the concept that you've taken is the correct one. It's, again, for you to work in partnership, not only with the patient, but the patients and the doctors. So working together, when I work with the psychiatrist that I send my patients to, it's always a much better outcome because we're constantly involved with the patient. But you spoke about Bob Harper. The biggest question, so we did this media tour, as you told the audience in the very beginning, all during Heart Month last year. And, working with Bob, he's such a great guy. He's such an exciting guy. And he's so full of life. And for him, and he talks about this publicly, so this is not a HIPAA thing. You can just Google both our names and you'll see what he's talked about it with me. But one of the biggest things was, it was a huge embarrassment for him. Here he is, one of the most fit human beings in the world, on national television, telling everybody else how to lose weight and how to be fit. And he goes and has what nearly killed him. So not only was it a devastating blow to him physically, but emotionally, it was horrible for him. And he had to come back from that. And, the worst part about heart disease in the old days is that people looked at it as the end of their lives. Get a heart attack, life is over. And what we tried to show, and what we have shown in cardiac rehab, and what the whole function of my world in practice clinically, is to tell people that heart disease is the beginning of your life. It's a beginning a new and better life and a healthier life. It doesn't mean giving up anything. It may mean portioning things, all right? But it certainly doesn't mean the end. And if part of that, if you want to climb mountains, you can climb mountains. And if you want to have sex day and night, you can with any partner you want. We just have to do it intelligently and make sure. The whole thing with Viagra, we were going to talk about it. But
talk about Viagra and nitroglycerin.
Yeah, I'm going to. It's a very interesting story. You'll crack up. You will crack up about this. And I'm not uncomfortable talking about it. When Viagra came out, who wanted it? I get these old guys who came into my office with their wives. And what they would do is at the end of the exam, the wife would say, I'm going to leave the two of you alone. And it didn't take me like 2 or 3 people to realize what's the next question. And the guy would say, Dr. Wexelman, I'd really like that pill. You know what I mean? I want the pill. And, and I would say, listen, we have to make sure that you can, many of these guys hadn't had an erection and hadn't had sex in 20 or 30 years. And now all of a sudden we're giving them without the state of knowing what their heart is about. It was dangerous. Now, of course, cardiologists didn't fall into this trap, but a lot of other doctors did. At the end of the day, Viagra is a great and safe drug for you, and it works like a charm in all ages. But if you're not able to do physical exercise, having sex is not going to help you, and you can just ask Rockefeller's family, all right? There's a guy that allegedly, had some issues during he had sex with actually somebody that was not his usual partner, and he died. And people think about that. So at the end of the day, if you listen to the ad for Viagra, it says, for people healthy enough to have sex. What does that mean? It means if you want Viagra and you haven't had sex in a long time, we do a stress test, make sure you can do the exercise. It's not the Viagra, it's the exercise. And then comes that old thing about, if you're taking nitroglycerin, you cannot take Viagra. So here comes the personal story, which I am now revealing to the world because I have talked about this in many of my talks before.
Because you love me, that's why you're revealing it to the world.
I am. So, I love how when I used to do lectures for Viagra in the heart. And you would say to people, so how many of you here have used the Viagra? Oh, no, I don't need it. Why not? What a pile of crap. All right. Men from the age of, late 20s, early 30s start having some forms of erectile dysfunction. And by the way, erectile dysfunction is the first symptom of atherosclerotic heart disease. We look at erectile dysfunction in men as the first sign that we better watch their hearts. But getting back to the story, so everybody tries Viagra, and I got so much samples of Viagra, and I got to tell you, it works like a charm. So one day, it was a Sunday. There wasn't a lot going on at home. And I said to myself, you know what? Let's take one and let's see how this all plays itself out. It would be nice to enjoy that. So I took it, right? An hour later, just as the Viagra was starting to work, I get a call from the local synagogue that has a catering hall. Seems they were having a wedding, and one of my patients, the family was there, and the guy had chest pain. And so the person says to me, the caterer knew me and knew they said, we have to call Dr. Wexelman, our cardiologist. He called me at home and he says, listen, you better get over here. I had taken Viagra an hour before. The last thing I really wanted to do was go to pray in the synagogue. All right. But it's my patient. So I get dressed, I get in the car and I'm going, look at the smile on your face. I love it. I get to the hall. I get out of my car. The paramedic got the guy into the ambulance. And you remember what they taught you to do when you use nitroglycerin spray is to do one spray to make sure it works and then give it to the patient? Just as I opened the door to the ambulance, the paramedic then sprays the nitroglycerin spray in my face. 1 hour into taking this Viagra. Now I have a real problem. First of all, I'm going to see this guy, and I'm figuring with all this hype about nitroglycerin and dropping the blood pressure and Viagra, I'm a dead man. What do I say? Do I say, I got to go to the hospital because I just took a Viagra and now you sprayed nitroglycerin in my face? I took care of the patient. I didn't say a word, and I'm sitting there waiting to drop dead on the floor. And you want to know what happened? Nothing. Not a damn thing. All right? So, I talk about this all the time, not saying that if you're on nitroglycerin, you can take Viagra. I think you need to really talk to your doctor. But this instantaneous death that we scare people about with it just really ain't so. All right. And needless to say, I went home and, everything was fine. It was really good taking the drug. But the nitroglycerin really, that gave me the worst headache I've ever had. I think you have to use it very carefully with nitroglycerin and, only with your doctor's supervision. And I think most doctors will tell you that if you're on nitroglycerin, you shouldn't take Viagra, Levitra, or the other drug. But what I would tell you is when my patients that have heart disease want to use a drug like Viagra, what we try to do is we try to keep them off the nitroglycerin and tell them that if they're going to take the nitroglycerin in an emergency to be very careful and to call the doctor first. But if somebody that's on nitroglycerin wants to use Viagra and that's important to their lifestyle, we give it to them. We just take them off the nitroglycerin. Nitroglycerin is actually becoming a lesser used drug in cardiology now because of a lot of the technology we have. So it's made it very easy. But at the end of the day, I think nitroglycerin is probably and nitroglycerin comes in a lot of forms. People use it as a patch on their body for 12 hours a day. People take it under their tongue, long-acting versions of it. So I think that, again, that's not something I would mix together. I did it by accident, obviously. But I would have the conversation with the doctor. And I think if a patient that's listening to us right now is on nitroglycerin and they want to use Viagra, they should have a real intelligent conversation with their doctor about taking them off the nitroglycerin. That's the best way.
I think that that's great. And thanks for sharing your story. It all kind of wraps back together, full circle here, that everything comes back to a conversation with your doctor or with a doctor who will listen to you. It might not be your doctor, but again, I think that means finding another doctor. And I think there is starting to be a movement here among physicians physicians as well, that they're demanding that they get that time back. And unfortunately, it means a lot of people are going to cash-based practices, concierge practices, and things like that, where their time isn't structured the same way and their time is valued and they can take the time that it takes. I don't know how you can do a full physical in 15 minutes and do your charting on the computer and all that as well. But I think that the pendulum is starting to swing back the other way. And I'm hopeful that physicians are going to be able to get time back with their patients. And I think that's really, really important before any of these questions that we've talked about today are going to be addressed. Because if I've only got 15 minutes with you and I have to do a full physical, how am I possibly going to have time to bring that up?
Yeah, it's hard. And I think, since you're working now on your own, it's very much different. But for doctors most of the cardiologists in the United States now are being taken over by either healthcare systems or major hospitals. And what they work on is something called RVUs, relative value units. And that's how they get paid. It's not what the patient pays them. And in essence, so everything is a certain time value. And they're paid to actually get people through the system faster, and see more. And so a lot gets lost. And I think that the dialogue that you and I are having right now is how the beginning of the dialogue needs to be nationally about how we took that oath at the day of graduation, and I took that oath very seriously, as did I know you, because I know that you were the biggest advocate for your patients. That was the beauty of you, watching you grow in that residency training program. You took great care of your patients, and, you cared about them globally, and that's why I was to try to get you to change to internal medicine. I wanted you to, I wanted you to come work with me. We can talk about that in the future. But at the end of the day, we need to start having that dialogue in national medicine. It's not so much about who's going to pay for everything. We have to get back to taking the oath that we made that day very seriously again. And that is to be the best advocate for the patients, to take care, keep people well, and do no harm. And doing no harm means we got to start talking to people again. And we can't be afraid, and we can't be intimidated, and we can't say there's just no time. We all fall into it. I may sound like I'm God's gift here, all right? But if you ask half of the patients I saw today in preparation to wanting to make sure I was done to do this program, I'm sure people felt that they were shortchanged with me today. It's a very difficult thing. People don't want to wait. People don't want to wait long times before appointments. People don't want to wait when they're in here. But they want all the time in the world when they're with you in the room. So it's a very, very delicate balance, Emily. And, I think that it makes us be our best. It really makes us be our best as practitioners. They've taken us away from, we were called doctors, then physicians. Of course, physician is the term I love because it means so much more. But now they look at us as prescribers, providers. We're providers. Me, you, the nurse practitioner, the PA, the pharmacist, we're providers. I didn't go to school to be a provider. You didn't go to school and spend all those nights and weekends in the emergency room taking care of one disaster after another to be a provider. We're physicians. This is a calling for us, and we need to get back to that. So I hope there are doctors that are listening to this, and I hope that they'll stop for a minute and say, what am I doing and how can I do it better?
Absolutely.
And we begin the dialogue.
Well, thank you so much, Dr. Wexelman. I really appreciate your time. I'm sure that all of our people listening today had got a lot of information. I know I did. I hope this isn't the last time that you're with me. I'm sure there'll be a lot more questions.
Oh my God. I'll be with you anytime you want. It'll be my pleasure. It's so exciting to do your show. It's like I knew you when you were a little kid. You've grown into this amazing woman and amazing physician. And I'm so excited. I will do your show any single time you want.
Well, I look forward to having you back on again. And thank you so much again, Dr. Wexelman.
Thank you very much. Take care.
Thank you for joining Dr. Emily Porter, the Austin Love Doctor. If you have a question about your relationship or sexuality, please feel free to contact her directly at austinlovedoctor.com.